Hi, it's Dr. Helen here from Dorset Allergy. So I'm well aware that I have promised to answer all of your questions that came in, and there are a few outstanding ones. So I'm going to make a series of videos addressing all of those questions that came in and going over some of the answers to the ones that we did on the live. I'm going to, excuse me for looking up and down because I need to read the questions that we have on the computer. So the first question is, should we be concerned about particles that are floating in the air, especially around food preparation, or does the food always have to be ingested to trigger an allergic reaction? So good question, and something that certainly lots of people are worried about. So allergic reactions can happen in a variety of different ways. So it isn't uncommon that somebody, for instance, could have an allergic reaction just because they've had contact with the food. So to give an example of my own son, when he was allergic to milk, I once had a latte, didn't really think about the importance of making sure that I'd washed my mouth, cleaned my hands. I gave him a kiss and he very quickly developed hives, so urticaria, just on his cheek where I kissed him. So you can have a contact reaction. And there was the really incredibly sad case of the young lad who had cheese thrown at the back of his neck, and he developed a really significant allergic reaction and sadly died. So that is one of the ways that some people will react, so with contact. Not always, but it is certainly known to happen. But as far as I'm aware, the serious case of somebody dying is the only case where somebody's died from a contact reaction, as far as I'm aware. Then, of course, you can eat the food and that will trigger an allergic reaction. And for some individuals, they will find that if they inhale the products, then again, that can trigger an allergic reaction. So it's via a respiratory route. And the commonest things that I've seen that happen too in practice is actually people with fish allergy. So some people with fish allergy, it's so severe that when people are cooking fish near them in their homes, then it can trigger off an allergic reaction just from the, the cooking smoke having the fish within it. And therefore those individuals will find that they can't be in restaurants, perhaps where there's like fish soup around, that they can't cook any fish products at home and they have to be really cautious. But that doesn't happen to everybody. So the challenges we have is that we're all different, our children are all different, and really it's a case of a little bit of finding out as you go, really. And it's not unusual that you will already have a gauge of that, because often with your young children, they'll have been exposed to what you're cooking at home and you'll have known whether or not these things have triggered reactions before. Particularly the thing people are worried about often is peanut allergy, and for instance being on an aeroplane, and whether if it's not a nut-free plane that perhaps the peanuts in the atmosphere going through the ventilation system may well trigger an allergic reaction. And actually that is incredibly rare. So for most people with peanut allergies, it isn't necessarily triggered by it being aerosolized, that's it going into the environment. There are a subset of people where it will, like anything, but the majority of people that's not going to happen. The challenge with aeroplanes being nut-free is unless they are constantly nut-free, then you could never say it was safe anyway. So for some airlines, what they'll do is if they've got somebody nut-free who's got a nut allergy going on board, then they might make that particular flight nut-free. But if previous flights haven't been nut-free, there's still the potential risk of contamination in your seat area. When you use blankets and pillows and things from on board, they're often just steamed, not necessarily deep cleaned, so there's the potential risk of contamination of nuts on those things. So really it's about taking sensible precautions. So I think if you're going on board a flight, wiping down yours and your child's area very carefully, perhaps asking people not to eat those products nearby you, if especially perhaps if you know that they are allergic and have had reactions which are triggered when there's been like the nut products in the environment, so when it's been aerosolized. But just sensible precautions really. But not necessarily meaning that you avoid flying altogether or not going on holiday just because of those allergies, because that's a bit sad really, and I think we should all enjoy holidays where we can. One of the next questions is eating something hidden in food that my child's allergic to but isn't listed, what problems long term can this cause internally to my child's digestive system? So I think if we think about that in a few different ways, one, if you're allergic to something, will you have long-term problems with your digestive system? Well, broadly speaking, there are two different types of allergy. There's the IgE mediated allergy, which most of us know about and are aware of, and it's the reactions that occur quickly after eating the food, so very often while that person is eating the food, and they last about an hour or two, and they tend to present with those classic reactions of hives, which is urticaria, swelling that we call angioedema, maybe immediate onset vomiting, diarrhea, what looks like hay fever symptoms, so runny nose, sneezing, congestion, itchy runny eyes, and possibly anaphylaxis symptoms, which would be problems with airway or breathing or the conscious level. And generally people know that they have those allergies because they're so obvious, and as long as you're avoiding those foods, there is no known risk up to the digestive system long term that I'm aware of, and there's no issues that are going to come from that. There is another type of allergy called Non-Ige mediated allergy, which on the whole, the commonest forms of that present in infancy, so around the age of 2 to 3 months, depending on what we're talking about. But there are some differences, but this is just generically, broadly speaking. And those infants present with perhaps early onset eczema that's quite difficult to control with regular treatments, gut symptoms, which might be vomiting, reflux, lots of loose explosive nappies, perhaps blood in the stool, mucus in the stool, what we call soft stool constipation. So they strain, and when they do go, it tends to be soft. They may get redness around their bottom. They may be quite congested, snuffly babies. And potentially if they have severe non-IgE mediated allergy, they may have issues with their height and or their weight. And this is something that's an area of sort of emerging evidence really, but we do sometimes, certainly when I was working in clinic regularly in Southampton, we would see that those children that had a very late diagnosis of non-IgE mediated allergy, or a potential misdiagnosis, so it was just something that they did grow out of, but when you go back over the history you think, do you know, I think you probably had a non-IgE mediated allergy to milk, for instance. They are the children who we quite commonly see coming through clinic with long-standing problems with tummy pain, constipation, or perhaps diarrhea. And there are thoughts that perhaps that's linked into what we call functional bowel disorders later on, so things like irritable bowel syndrome. So those are things that don't actually mean that the child has a problem with the structure of the bowel, and there's no chemical imbalance, but irritable bowel, as you might know, we can't fully explain, but it certainly has quite a significant impact on a person, and sadly the treatment options for it are quite limited, so it's really about lifestyle management. So if you have a non-IgE mediated allergy and it isn't picked up or is potentially missed, then potentially that person may go on and develop those issues as they get older. Generally, I would say most of us know what that person's allergic to. So unless you think you've got your child has got undiagnosed allergies, and they're generally going to be of the non-IgE mediated type because they have quite an insidious onset. So the timing is not clear after eating food. It can come on anywhere between days and hours and a few days later, and there's not always a clear pattern of timing when you're eating foods with non-IgE mediated allergy. So potentially infant or young child may have non-IgE mediated allergies that haven't been picked up yet, and you may just feel that your child has ongoing issues with bowel symptoms particularly, and being very unsettled. So yes, if it's in that context, there is the potential that they may go on to get these bowel issues as they get older. So quite a complicated answer, but I hope it's given you some guidance. Somebody's asked, do children become fearful of certain coloured foods, which then impact on them trying a food that they're not allergic to, but maybe the same colour? So I don't know the specific evidence around the colours of food, but I do know that children can become quite fearful around foods that look similar. So for instance, if a child has an allergy to milk, cow's milk, we always encourage that there's still a milk substitute that's used in the household. So be that soya milk or oat milk or almond milk or whatever that person is able to have. And that child is then doing things like pouring it on their cereal or having alternative products, but having the texture of the milk and seeing it in the environment. Because certainly then, if there comes a point where it looks like they've outgrown their milk allergy and you're trying to reintroduce the milk, it's a lot easier for them if they've been used to those textures and what it looks like, and they do seem to be less fearful of it. Equally, there's some thoughts around that with nuts. So if you're allergic to peanuts, if you're able to eat tree nuts, we still encourage children or adults to eat the tree nuts, but particularly in this context, we're talking about children, because it does help, again, because they're used to the textures, the flavouring of nuts, and they're not then quite so fearful about putting that original nut that they were allergic to back into their diet, because they've been used to handling nuts. And I found that with my own little man. So he was allergic to almonds, but because he had positive skin prick tests, he was told to avoid all nuts. And certainly years ago in allergy clinics, that was what we used to advise. We would say, okay, if you're allergic to one type of nut, then avoid all of them, generally speaking. And then when the time came that it looked like he'd outgrown his nut allergy, he was incredibly fearful of reintroducing them for fear of having an allergic reaction. In the fact that he wasn't used to the texture and tastes of them, and it was much more difficult. And our psychologist sort of said it is easier if people have been used to those textures. So based on those two things, it does follow that for some children, if a food looks very similar to something they are well aware causes them a problem, particularly perhaps if they've remembered the allergic reaction, but even if they've been told don't eat that, you mustn't eat that, it will, it might give you a serious reaction, or sometimes we might say things like, oh, it might kill you, because we're trying to impart the seriousness of it. It follows, of course, that they may well get anxiety around those specific foods that look similar, be that in colour or texture or shape. So yeah, something really difficult. And I always find it quite fascinating that we see anxiety, so much anxiety that exists in families, in the caregivers and in the young people when they have food allergies. And there are some studies that have shown that the quality of life of those with food allergies is worse than somebody who has, for instance, type 1 diabetes. And bearing in mind that type 1 diabetes means that you have to do regular finger prick tests to check your blood sugar, regular injections, that really has very significant long-term consequences potentially on health. I find it staggering that food allergy for many would not, for the majority actually, would not impact on length of life, and yet it causes so much anxiety and upset. And whilst I was quite a chilled mum about my son having food allergy in many respects, I think, and therefore I was surprised at Ethan being around me as his kind of role model all the time, and although saying, be careful what you eat, you must ask if it's got milk or nuts in it, actually his anxiety was massive, and that became more apparent the older he got. So it's something for us to be aware of, and that's why I think if allergy clinics have psychologists involved in them, it's a fantastic resource, because they are so helpful for both parents and young people as they struggle. So somebody said, do cow's milk protein allergy babies have to have breast milk until they're 2, or can they have a plant milk alternative? So I think that's a lovely question, in that it would be fantastic to think that everybody with a cow's milk protein allergy was being breastfed, because we all know that breastfeeding provides so many benefits to mummies and to children, and there is some thoughts and evidence that if you can continue to breastfeed alongside weaning, that it reduces the chance of other allergies from forming. But the very big reality is that the majority of children won't be breastfed for many, many reasons. Choice, which is important, but moreover, usually it's because of challenges that mum had, challenges that baby had, that mean that actually the bulk of our babies with cow's milk protein allergy are likely to be formula fed. And also, if you look at the likelihood of milk allergy forming in breastfed babies, I think it's 0.5%, whereas it's much higher in formula fed babies, so around 2 to 3%. So therefore, most babies with milk allergy are going to be formula fed. So as I've talked about, it's important for those with milk allergy to be using some sort of substitute in their diet, in terms of having it on the table to add to your cereals, to have like yogurts alternatives if you can, and to have that texture of milk in cooking and things like that. So most children, little ones, will be having an alternative. We would then recommend that the babies are either breastfed or having their formula at least until the age of 1. And for some of them that may have issues with their growth or their height, so their height and their weight, or multiply allergic, then we are usually going to advise that they continue with their formula, their cow's milk protein free formula, until the age of 2. And often that's directed by an allergy clinic. And for breastfed babies, some of them will continue on till 2, but having breastfed myself till my children were 18, 19 months, that is quite a big undertaking. And certainly if you're back to work, you're probably going to find that they're not necessarily getting good quantities of breast milk from you. So it's something that you can choose to do. But actually from 1, most children are going to be able to switch on to an alternative. And if you have a cow's milk allergy, the best alternative you could use would be soya. And these days the soya that you buy, we often recommend the Outpro Soya Junior, which is the one with the giraffe on the side. They're fortified in vitamin D and calcium, but so are many of the other substitute milks like oat milk and almond milk and coconut milk even. They often all have the fortified vitamin D and calcium that's important for the children. But the difference is that the soya milk has a higher quantity of protein, and protein is needed for growth. So when you've got, when we're talking about growing children, the higher the protein content, the better. And that's why if a child could tolerate soya, then that would be the one that we would be opting for. The challenge we have is that if you have a non-Ige mediated cow's milk protein allergy, and that's what the bulk of these babies are going to have, 50% of them will also have a non-Ige mediated soya allergy. So many of them wouldn't be able to tolerate that. If you have an Ige mediated cow's milk protein allergy, only about 10% of them will have a soya allergy. So we generally recommend that it's tried and you see how they get on. So my little man had a non-Ige mediated cow's milk protein allergy, and then he switched into an Ige mediated cow's milk protein allergy, but he could always tolerate soya. So soya formulas are not recommended below the age of 6 months because they contain something called phytoestrogens, and there's a theoretical risk that it may feminize babies. Now, in actual reality, there isn't any clear evidence that happens, but NICE, which are our kind of guidelines, don't recommend that it's given below 6 months of age. But over that, it could potentially be tried. And as I say, my son loved it. And at that point, and he's nearly 13 now, there were not very many milk-free alternatives on the market. So soya was brilliant because we were able to give him soya yogurts. I could freeze the soya yogurts and make ice cream. We could use soya in our cooking. And I could use it as an alternative while I was breastfeeding. In actual fact, I hate soya and it tends to upset me, but we do these things for our children. Now, with the advent of lots of people looking for milk-free diets to be more plant-based, there are lots more alternatives, many more alternatives for children and adults with who are avoiding cow's milk for whatever reason. So the answer to it is you don't have to maintain breastfeeding till 2 if it wasn't right for you, and you could use a plant-based substitute instead. So somebody's asked me that they have a 1-year-old who's got a nut and an egg allergy but never actually had them, and they said, what age do I think that they could try them? So I guess this comes down to, why have you been told that they have an allergy? And I suspect what's happening here is that little one probably has eczema and undertook some allergy skin prick test for whatever reason. Perhaps they're allergic to something else, and it was decided that they had skin prick testing, or other common scenarios are that they have a sibling who has allergies and the family request that the little one has allergy skin prick tests or perhaps blood tests before they're weaned. And herein really lies the issues that we have with testing. So currently the 2 ways we have of doing an allergy test are by doing a skin prick test or a blood test. Now, skin prick tests are only done in specialist clinics. And if you're not aware, what they involve is basically you write little letters on the forearm here, so you know what you're testing. So like C for, I don't know, cashew nut, P for peanut. And you put little droplets of solution that contain those things next to the letter. And you pop the bubbles with a lancet, which is a sharp device, which basically just pricks the top layer of skin. It feels a bit like you've poked yourself with a sharp pencil. So it really doesn't hurt, and very often babies just don't react at all. It shouldn't draw any blood. And then you wipe the bubbles away, so the solution away, and you leave it 15 minutes, and you're looking to see if they get a raised bump, so a hive there, and you measure it. And generally speaking, if it's over 3 millimeters, we call that positive. And to know that the test has worked, we do 1 prick of a solution with salty water, so saline, which a normal person wouldn't react to, and 1 prick with histamine, which is the chemical that's released in an allergic reaction. And again, to show the test has worked, that one should be positive. So you should have a raised bump by the histamine and no bump by the saline. So that's one of the ways we do the allergy testing. In primary care, so GPs, they have access to doing the blood testing, where you're looking at the specific IgE against something. So the IgE of peanut, the IgE of milk, the IgE of cat, dog, and GPs have access to that. And if it's over 0.35, then we call that positive, and the most it goes up to is over 100. But the challenge is that these tests are not 100% accurate. So I have people who will give me a really clear history of an IgE mediated allergy. So they'll say, classically this happens with sesame allergy. Every time I eat sesame, I develop hives, swelling, I vomit, and it's come quickly after eating the sesame and it's gone quickly. And I might do a skin prick test and a blood test perhaps, and they might both be negative. And yet I'm thinking, there's a really clear history of allergy here. I'm really suspicious. And in that case, what I would then normally do is arrange a food challenge where the person goes into hospital for half a day. They have a very small amount of sesame to begin with, and they're monitored for 15 minutes to make sure there's no reaction. And then they get a bit more, monitored for 15 minutes, a bit more. And by the end of a morning or an afternoon, they would have had a normal size portion for their age and either had no reaction, or of course the challenge will have been stopped because they will have reacted. And only if we've done that can we then say you don't have sesame allergy, or you do. So you get false negatives. More commonly though, we get false positives, and this classically happens in those with eczema, and they are what we call sensitized. So basically they have enough IgE in their system to produce a positive skin test or a positive blood test, and it can be really positive. So their IgE in their blood could be over 100, but all it shows is that they're sensitized. And so for instance, it's not unusual with those with eczema that somebody's done a allergy blood test to see what's triggered their eczema. And the answer to that is not food, because eczema is not caused by food allergy. But somebody who hasn't understood that's done a blood test. And then they come back, say, with positive tests. So I once had a girl who had late onset eczema, so she was about 12, and a dermatologist arranged for her to have some blood tests, and they came back positive to all the nuts. So I spoke to her in clinic and I said, did you ever eat nuts? And she said, oh yeah, I did. And I said, did you ever get immediate onset hives, swelling, vomiting, diarrhea, etc.? And she said, no. And all the blood tests were showing is that she was what we call sensitized. So it showed that she had essentially a false positive. So her body produced enough IgE to give you a positive test, but not a clinical response, i.e. not an allergic response. And the risk and the worry of doing that is by then taking that food out of the diet just based on a positive test, there is a real risk that that could allow allergy to form. So blood tests and skin tests, in my opinion, generally should, wherever possible, be only done if there's actually a history of an allergic reaction. Now, for this little one, I suspect what's happened with mum saying they have an allergy but they've never eaten it. So clearly we are only going off positive tests, but they've never actually eaten it. So we don't know whether they're truly allergic or whether they have these false positive tests. So they're just called sensitized. And as I said, that's commonly being done in those with eczema. So the reason some people will do it in clinic is because maybe they've reacted to peanut, for instance, and the family say, well, I don't want to give the tree nuts, so cashew, pistachio, walnut, hazelnut, until I've had an allergy test. And so they have the allergy skin prick test done and they may be positive, but you never really know, well, are they allergic or are they just sensitized? And that happened with my own little man. So he had almond and he had an allergic reaction. So he had hives and swelling. And so in clinic, I then didn't give him any more nuts. And in clinic, he had skin prick test done to all the nuts and they all came back positive. So we were told to avoid them. And the challenge is by not eating them, it can allow allergy to form. Because you're not getting it into your diet and you're not then developing tolerance against it. Thankfully, what happened is as he grew older, the skin test and the blood test became negative and we were able to have a food challenge and show that he wasn't allergic to it. But, you know, we waited 8 years for that to happen. And in that meantime, as I've said, he developed massive anxiety around nuts to the extent that at almost 13, more often than not, he won't eat nuts because he says, oh, well, I might react to them. And yet, you know, you're saying you are very unlikely to these days. So that's one of the reasons it's done. Other reasons it's done as a kind of screening test to see are you allergic or not is, as I've said, if somebody's got a sibling who's got lots of allergies, then sometimes the anxiety for those families of having a little one that they're worried about whether they might have a reaction or not, they decide to have skin prick tests done in an allergy clinic. But I don't always feel that comfortable with that because they do then have this unknown of am I allergic or not. And in reality with a screening test, there should be an endpoint that you know for sure, am I allergic or not? And so for me, it would be, we've done a skin prick test, it's positive. And then I would say the next step should be, here's a food challenge to know, are they allergic to it or not? But it's not done because A, we don't know the safety of doing that within the screening of, you know, should we be following all of these positive screening tests with food challenges to know if they can eat it or not? But mainly because there's just not the resources. So in Southampton, when I worked there, and it's been a few years since I worked there, at a big main clinic, our waiting time for a food challenge was about 9 months. There's no way we could accommodate doing it for everybody to all the different foods to see was your skin prick test falsely positive or accurate. So generally speaking, where I can with my families, I encourage them to try the infant with the food to know whether they react or not. Because yes, allergic reactions can happen and they're horrible. Having experienced it with Ethan when he was 6 months old, I gave him Dairy and he swelled up like a massive balloon. It's horrid. I've never felt fear like it. And even in my mind, I knew like he wasn't having anaphylaxis because he didn't have breathing problems or any issues with his airway. But actually, I was totally panicked in the moment and ran to the chemist with him to get some antihistamine and sat in the park feeding him, you know, Puriton to help it. So it is horrible. And anaphylaxis can occur in infants, but death in weaning infants haven't been reported. And therefore, in many ways, I feel we should know for sure rather than not know. So what I generally suggest is we just start with really tiny amounts. So on a day the child's well, if you're introducing, say, peanut, you just give the very tip of a teaspoon and you watch and you check that there's no reaction. And if there isn't, on day 2, you give double the amount. And if that's okay, on day 3, you give double that amount. And on day 4, you give double that amount. And by that point, you could probably be confident that they're not reacting, and you could move on to the next allergen, i.e. the next food that you're testing. And for me, I think that is a more sensible thing to try. But I fully appreciate that we all have different opinions about that as parents and as allergists. We have different opinions. So for this particular little one, who therefore sounds like they've had a positive skin prick test or a blood test, the answer is that the right time to be trying that food is going to now, unfortunately, be when they no longer have a positive test. So for egg, we generally follow those infants up yearly until they become school age, so about 5. And we do that with milk as well. And that's because milk and egg allergies change very quickly in the first few years of life. But with nut allergy, because things don't change quickly, we generally follow them up every 2 or 3 years. So I suspect that the allergy clinic will follow them up every year or 2. And if the skin prick tests come negative, we would do a blood test and confirm that that was negative. And then it's a conversation to be had with the allergist. But most of us would then recommend that the food was given in a hospital food challenge first to check that it was safe, certainly with nuts. With egg, we will do home introductions of egg with things like baked egg first, so checking that they can tolerate it in, say, like a cupcake, and you'd be given guidance from that. But certainly it's not something that you should be choosing to just try on your own at home, because now you have a positive test, there is the risk that there's going to be an allergic reaction. Okay, my last question for this little section, because it's a long video. Is it possible to carry on living with a cat if you found out that your child has a cat allergy? So here's my confession. Both of my children have cat allergies, and we have 2 cats. So it isn't a no, you mustn't have an animal. It's a what's the reaction that we're describing. So when you have an allergy to an animal, there are different ways it can present. It can present with like hay fever type symptoms. So congestion, for children, they often get really blocked noses. I do have to put up with my daughter snorting like Darth Vader all the time because she's allergic to the cat. They might sneeze a lot. They might get runny eyes. Moving one step further in a more significant reaction, when my daughter, who's the one that's particularly allergic to cats, was around some types of cats. So we went to see a special breed that were lovely, but she came out of there completely swollen. She was so swollen. And when the cat licked her or one of them scratched her, then she came up in hives. So some people will get swelling and rash around it. One step further than that is some people can get significant breathing problems around animals, and particularly cats really trigger it more than dogs, but it can happen with dogs as well. But cats and horses, they're the worst ones that trigger breathing problems. So clearly, if you have a child with breathing problems around animals, then yeah, you've got to get rid of it. And the other issue that you sometimes have with animal allergies is, say, that you might have a young person or an adult with asthma. And day to day, they may be fine with their cat seemingly, and it might not seem to cause them a problem. But you know they're allergic, perhaps because you've had a blood test or a skin prick test, or maybe they just get some mild sneezing. What can then happen is if your child or the adult then gets an infection on top, sometimes having that animal around will just completely tip the balance. So you find, like, say you've got your asthma and it's kind of controlled, but we're already slightly tipped because we have a cat at home. And then you get an infection and you're tipped even further. And then what may well happen is you're finding that person is needing oral steroids, which of course have long-term risk. They're being admitted to hospital. They're having nebulizers in hospital. So for anybody who's got asthma, if it is badly controlled asthma, if they are needing repeated doses of steroids or they're having repeated admissions, then my advice would be you need to get rid of the cat and the dog. If you have anybody that's around a cat and a dog or whatever animal and you're getting clear breathing problems, then you can't have them. You've got to get rid of them. Or maybe a new diagnosis of asthma and perhaps it's triggering from the cat that you've just bought. You've got to get rid of them. What happens with my middle daughter doesn't have asthma. She's just snotty, and if she puts the cat in her face, her face will swell a little bit. We have antihistamines at home. We use it as that, and we just encourage her to not shove her face right in the cat. But yes, she can stroke, and for some children it may be that they don't have the cats or dogs in their bedroom, they don't go on their beds, and they wash their hands after handling. And you have to think about the benefit of animals to quality of life and mental health for children as well. And so for some it's really important. My son is more tricky, I have to say. He does have asthma. He is allergic to the cats. His asthma is not always brilliant, and certainly when he has put the cat in his face, which he always does because he's definitely Dr. Dolittle, his asthma can be a bit difficult. And it's a bit of a choice really of what you choose to do with that, and I think he'd be devastated if we removed our cats from the home. So we just really try and discuss with him the importance of good asthma control, of using his inhalers, of being much more sensible around the cats, taking them, you know, not putting them in his face, trying to get them off his bed. And it's a risk that as a family we've chosen to take. So not a clear answer, because it's different for everybody. And the other thing to bear in mind, when you remove an animal from the home, if it's been there for a little while, it will take some time before the animal kind of dander is removed. So there'll need to be lots of hoovering, lots of dusting, but certainly that, you know, you may well find that, I guess, remnants of cat are around for quite some time, and therefore sensible to keep these animals out of your bedroom, particularly if you're an allergic type person. Okay, I'm going to end this video for now, and I'll start another one and answer a few more questions on that. Thank you.